This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast also offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME will be in the show notes. This week, we are going to be discussing treating methamphetamine use disorder with Bupropion and Naltrexone. John, how are you doing tonight?
I'm doing great. Just finished up a wonderful 13-hour clinic stretch, so I'm ready to talk about some exciting new stuff.
And I'm good. And I want to know for our audience that you're also on call. So, if there's some interruptions, I'm sure they'll forgive you. But, no rest for the weary here.
Yeah, living the dream.
So, John, anything you want to share about addiction news this week?
Yeah, I saw this interesting article, and it's from The Conversation, and it's about a fentanyl vaccine. So it's entitled, "A New Fentanyl Vaccine Looks Promising, but Treating Drug Addiction Needs a More Complex Approach." And I think I've always been interested. I've heard in passing about like a cocaine vaccine, a methamphetamine vaccine in the past. And to be quite honest, I there's like something I heard about. I didn't know anything about it. And so this article was talking about a 2022 study. It's a rat study where they looked at a fentanyl vaccine given at week 1, 3, and 6. And essentially, like how the vaccine works is it stimulates an antibody response that binds up fentanyl molecules, preventing them from crossing the blood-brain barrier, so that you never get the euphoric effects. And so, interestingly, not only is it kind of targeting the euphoric effects, but also that's kind of where your respiratory drive is. So it doesn't cause the respiratory suppression associated with opioids, which leads to most of our overdoses. And interestingly, I thought it was kind of also interesting how they test the vaccine. They took these rats and they gave them the vaccine, and then weeks later, they would basically put them on these hot plates to burn. And like if they felt pain, they got off the hot plate. So rats that didn't get the vaccine, they stood on the hot plate longer, and then the rats that got the vaccine got off quickly, so the fentanyl wasn't effective. They also flick their tails, and if their tails cause them to get all upset, but with they have fentanyl in their system, they don't care if their tail's messed with. So I don't know, anyone that has a cat, I think, can relate. And then they did at the very end of the study, they basically just drugged the rats up to toxic high levels of fentanyl, killed them, and took samples of the brain tissue to see how much fentanyl actually crossed the blood-brain barrier. And it seems like it's kind of effective at kind of doing that effect, so decreasing kind of transmission to the blood-brain barrier. And, the article talks about is this really kind of a viable treatment option? I think it's very interesting as a primary care physician, and when we love our vaccines in primary care, I'm just not sure, how this would fit in per se. Certainly it's a 3-dose series. You could just switch to another drug. So a non-opioid or a different enantiomer of fentanyl would not work with this vaccine. It has to be very specific to fentanyl. And then kind of anecdotally, I'll be honest, my patients in my addiction clinic are my most vaccine hesitant patients out of my entire population. So I don't know if they would be big biters on a vaccine. What do you think about that?
Well, the idea is pretty awesome. Again, right. It's all in the details. How long is the protection going to last? How often do you have to come in? Is it just last a year and you have to get it every year? How much does it hurt? I mean, in some ways, I kind of feel like long-acting injectable buprenorphine is like a fentanyl vaccine. You get that shot once a month, and then the fentanyl's a lot less effective. But I think the idea is awesome, and it seems like it would be the kind of thing you could give people who are in treatment. Like if someone's entered treatment and decided they definitely need help, sure, get the vaccine, then it'll make relapse more difficult. I guess you just don't get the euphoric effect of using the drug.
That's essentially it.
Right. I mean, I guess the difference between that and buprenorphine is a partial agonist, so you get some of that dopamine that you're missing, compared to naltrexone or just an antagonist.
Yeah, I would think it would have more of a user-friendly engagement, right? Because I think there's other effects besides just blocking that you get with the buprenorphine. You get the partial agonist, exactly.
Right.
But I think more tools in the toolbox is always a good thing. I think that I look at our field in general, and I think that we have effective treatments, but I really do think we have a handful of ones that we kind of keep reusing and recycling in different manners. And I feel like if I see one more study about topiramate, Wellbutrin, or mirtazapine off label for something.
Right.
It's the same players. It's like the same 5 dudes just hanging out, like in the addiction medicine, like, treatment toolbox. It's like buprenorphine, methadone, acamprosate,
Right.
and like someone's like, "Hey, disulfiram, how'd you get in here?"
Yeah, right. Like the bat boy
Yeah,
on the bench.
yeah,
Yeah, well, I'm be super interested to hear what happens with it, and it opens up ideas for like maybe it's something you give to teenagers before they leave the house, just like their meningitis vaccine, before they moved out to college. I guess there's a lot of potential for it.
yeah. It's interesting. How about you? What did you read about or learn about this episode?
Well, I read this article that I don't know how we haven't all been talking about this. It was this incredible article in Reuters called The Fentanyl Express, and I think everybody should read it. It's really a gripping read. So basically, a bunch of reporters from Reuters did an investigative piece on how you make fentanyl, and to do this piece, they themselves went and purchased the materials needed to make fentanyl pills. So they just wanted to see, was it doable? So they went on the internet, and they didn't even need to go on like the dark web or do anything crazy. They just bought stuff on the regular internet. They looked at the instructions online, what precursor chemicals they would need. They bought all the precursor chemicals, and they bought a pill press with little dye to imprint it to look like OxyContin. And the whole kit and caboodle cost $3,600, and the stuff they bought was enough to make $3 million worth of fentanyl pills.
Wow.
And so it's just incredible. And then the article details how they did it, where it came from, and they tried to then chase down the supply chain of all these chemicals globally all over the world. And after you read this article, you realize that like that's why this problem is so difficult, because basically anybody can order the material to make fentanyl online for very little money.
That's incredible.
I'm
going to read that article. It sounds really interesting to read. And I think that's really scary.
It is scary, but it's also fascinating. All their conversations, all the conversations with the people who worked at these different chemical companies all over the world, and which ones came just in normal label boxes and which ones were sort of hidden, coming disguised as cat food. Some they just order from Amazon. And as Amazon's like, well, it's a legal chemical, we can sell it, Oh, so interesting. So I'm going to put the link in the show notes, and everyone's got to read this. So on that note, so some people will be making fentanyl, and then other people will be desperately trying to vaccinate us against said fentanyl.
Yeah. And the war continues.
I know, right? The war on drugs. So, John, you want to tell us about this article?
Yeah, so this one's not an opioid-related article. It's about methamphetamine, which is something I think we're seeing more of. So that's kind of why I picked it. So this is called Extended Observation of Reduced Methamphetamine Use with Combined Naltrexone plus Bupropion in the ADAPT-2 trial. And it's from Addiction of June 2024. A little bit of background. Methamphetamine is the second most widely used substance globally, with usage increasing from 33 million in 2010 to 34 million in 2020. I bet you if you looked at it now, even much more so. Some people have kind of talked about this being like the fourth wave of the opioid epidemic, kind of co-concordant opioids with methamphetamine use. Overdose deaths have risen significantly, particularly in kind of the more developed world, so U.S., Canada, Australia. No FDA-approved medications currently exist for methamphetamine use disorder, so a common problem that we don't have an FDA-approved treatment for. Bupropion is a stimulant-like antidepressant. It targets norepinephrine and dopamine systems, potentially alleviating withdrawal dysphoria and also reducing continued methamphetamine use through cravings. Naltrexone, on the other hand, is an opioid receptor antagonist used for opioid use disorder, and it shows modest efficacy in preventing alcohol relapse by reducing basically the reinforcing effects and cue-induced cravings, which may be beneficial in conditions such as methamphetamine use, kind of blocking these euphoric effects of the substance use. The ADAPT-2 trial was a big trial from May 2017 to July 2019. It was a multi-site, randomized, placebo-controlled trial evaluating combination extended-release naltrexone and extended-release bupropion for severe methamphetamine use disorder. Early results from the ADAPT-2 indicate that naltrexone plus bupropion was effective in treating severe methamphetamine use disorder, with a modest but statistically significant overall treatment effect of 11.1% in the first 6 weeks. That's reduction in kind of methamphetamine positive urine drug screens. The trial sequential parallel comparison design leaves data on changes beyond that period of time somewhat nebulous and unknown. So this is kind of a follow-up reanalyzing the second part of the trial, which is 7 to 12 weeks. And the clinical question is, does continued treatment with extended release injection naltrexone plus extended release oral bupropion for 12 weeks result in greater reductions in methamphetamine use compared to placebo in individuals with methamphetamine use disorder? Sonya, what are you seeing kind of in your clinic with kind of methamphetamine use?
I think definitely there's a lot of methamphetamine use, at least at my kind of outlying clinic that's a little more out in the country. The struggle I have is almost all patients come to me specifically for opioid use disorder, so I can't really use naltrexone because they're on buprenorphine, which is like the point of coming to my clinic. So I haven't ever been able to use naltrexone for methamphetamine use disorder. I've had to use, some other things, and but it's definitely a problem. It's a huge problem for some of my patients. And they're very surprised when I say, hey, there is treatment for this. We could try medications to help you with the methamphetamine too. They haven't really heard of that. So I think any data is good data.
Yeah, I feel like this is an area where we have kind of a paucity of data. So that's why I thought I wanted to go over this trial. But certainly something that we encounter frequently. And you're right. I also often find like methamphetamine use and people who've been meeting criteria for methamphetamine use disorder. I feel like mostly people are meeting kind of polysubstance use disorder criteria. So substance use disorder criteria in multiple different substances. So it's kind of hard to treat because you're kind of hitting different silos at the same time of illness.
Yeah, agreed.
So method. So the study design, this is a secondary analysis of 403 ADAPT-2 participants that assessed changes in methamphetamine use from urine drug screens during stage 2. So that's weeks 7 to 12 and post-treatment weeks 13 to 16 for those who received naltrexone plus bupropion in stage 1 compared to those on placebo. A little bit about the ADAPT-2 trial, since this paper really didn't go over that specifically, but just to give you some background of like how it was set up and kind of those preliminary kind of results of kind of the first phase. So the ADAPT-2 trial is, like I said before, is a double-blind, randomized, placebo-controlled trial conducted across 8 NIDA sites from May 23rd, 2017 to July 25th, 2019. The total duration of the trial was 12 weeks of active intervention, and it had 2 6-week stages, and it had an additional 4 weeks of post-treatment data collection. So stage 1, 6 weeks, stage 2, 6 weeks, 4 weeks of data collection after treatment. It was a sequential parallel design with initial randomization to the naltrexone and bupropion group or placebo. And if you did not respond to the placebo during phase 1 of the trial, you could be re-randomized again or have the possibility of re-randomization to the treatment group with the active naltrexone and bupropion on stage 2. So treatment response was basically assessed almost predominantly via urine drug screen results that were negative for methamphetamine. So that was the surrogate marker of success here. The intervention, like we said before, they did extended release naltrexone. They did 380 milligrams. And normally that's a Q4 week medication. Here they did it Q3 weeks, which I have used this kind of off-label before when like the medication is kind of wearing off towards the end. So it is acceptable to do that. It is kind of not the typical dosing parameters for that. Or placebo administered via IM injection on weeks 1, 4, 7, and 10. So basically you got a sham injection or the medication every 3 weeks. And then you got extended release bupropion starting off at 150 with a ramp up typically to the 450 milligrams, or you received a placebo tablet.
John, why did they do the every 3-week dosing? Did they say?
Yeah, they mentioned they thought that it was because that this was basically to block the reinforcing effects of kind of the methamphetamine use, but also the cravings. And they thought that kind of there's typically a tail during that 4th week, and so I think that's why the rationale was for the 3-week medication.
Mm-hmm.
Yeah, it was interesting. I kind of picked up on that right away too. So inclusion, exclusion, this is kind of important. It's a relatively narrow defined group. So this is adults age 18 to 65 who desired to quit or reduce methamphetamine use. So first of all, they wanted to quit. They met the DSM criteria for moderate to severe methamphetamine use disorder. They used methamphetamines 18 or more days out of the past 30 days. So this is a heavy kind of use group. They had two or greater methamphetamine positive urine drug screen results within the 10 days prior to randomization, and they were opioid negative. So kind of very select subgroup of adults, meaning criteria for moderate to severe methamphetamine use, incredibly high user. So not your casual user. This was kind of more days out of the month than not. They were using kind of up to the trial, and there was no opioid co-use going on. You were excluded if you're already enrolled in a substance use disorder treatment program. If you intended to use medical opioids during the trial period, so you had a planned surgery or procedure coming up, you were excluded. And if you were deemed by the investigators to possess a safety risk, you were excluded. Primary outcomes were estimated changes in methamphetamine use based on urine drug screens during stage 2, so that's weeks 7 to 12, and post-treatment 13 to 16. And during the post-treatment phase, people were tapered off of these medications. So this was not like a continuation of therapy. Among participants who received these two medications, data collection was twice weekly urine drug screen samples during the active treatment phases, so phase 1 and 2, weeks 1 to 12. And then once weekly UDS samples were collected on week 13 and 16 during this post-treatment phase. They did this kind of very complicated, complicated to a non-statistical, non-statistician about this piecemeal mixed effect logistic regression to compare odds of negative urine drug screen results between the two groups over the 16 weeks. And they did this kind of multiple imputations to address kind of re-randomization bias. So, kind of by selection, the second phase was possibly a more severe subgroup because throughout the initial trial, even though that there was a statistically significant improvement in kind of methamphetamine negative urine drug screens in the treatment group versus the placebo group, that actually both groups did have improvement throughout the trial. So basically, you were kind of selecting out the group that didn't improve on their own with time, as many substance use disorders can.
Mm-hmm.
What do you think about that kind of trial so far?
I mean, so far so good. I'm really glad they have the placebo arm and not just, medication compared to nothing or just sort of a prospective cohort study. I think it's good. The outcome of abstinence is good. I mean, in the end, that's what people want. I think at this point, this is a while ago now, a lot of times we're thinking about just, reducing use as opposed to seeing if people are totally abstinent. I don't know if they included anything like that or it just was positive or negative urine.
Yeah, it sounds like the primary outcomes were drug screen results that they were looking at.
But I think it's good.
Yeah, so it's this trial valid. So, I guess this was funded by a NIDA grant and the Department of Health and Human Services with Alchemier's providing Naltrexone, so Vivitrol provider, and the placebo at no cost. Researchers, as in many of these drug trials, they do have kind of various conflicting financial interests. And it's hard because a lot of times they do have kind of either kind of receiving stipends or research grants from pharmacy. And that's kind of how they make their living. So nothing kind of negative about that. It's just kind of the nature of running kind of randomized trials. The use of naltrexone and bupropion in this trial, it is scientifically plausible, right? The mechanism of action does lend for a potential target for methamphetamine use. The studies did a secondary analysis of the ADAPT-2 trial. So this is nice. Like, I love these for addiction medicine. We don't get a ton of these. It's a double-blind, randomized, placebo-controlled trial with sham injections of 403 participants. So that's kind of a very nice design. And certainly, just like we talked on the first thing about that there was some industry funding, it takes money to run a trial like that.
Mm-hmm.
The sample was very specific, like I stated before. I think that was not like a problem with the paper. I think it just kind of limits the generalizability of these results quite a bit because, it's adults only, pre-retirement adults, although I'll be honest with you, I don't think I have any over 65-year-old Medicare patients that endorsed methamphetamine use to me that I can recall. They have no opioid use, and not only that, they kind of are heavy users, so kind of using not just casually. This is like 18 plus times per month or 18 plus days per month. One thing that I kind of thought of too is that is a phase 2 analysis, and so they talked about that there could have been some affected changes by the placebo group re-randomization. So the fact that these were not kind of randomly selected, it was like randomly selected amongst a group that was not randomly selected, so it was a non-responder group. That does kind of limit some of the statistical validity of this. Interestingly, the first part of the trial, they designed that sample size very specifically with a 90% power to detect significant difference. So basically, you are looking the trial was designed with a size in mind for their statistical analysis for the first phase. So this second phase, it may limit their reliability of the results. Just the fact that like they're basically doing these computations to account for the fact that the trial wasn't sample size to a point that was meant to have that degree of power. I think the 12-week duration may have been too short to capture the gradual change in patient behavior, often associated with recovery and methamphetamine use disorder. So certainly it was on the shorter side of a trial, but like I said, it seemed to be otherwise, I thought, a very good trial.
Mm-hmm. Yeah, I mean, I agree. I think it was a valid trial. The placebo arm was very nice to have. It's a good question to ask. It's big enough, over 400 people. So yeah, I mean, I think it was a good trial. And I did like offering that sort of additional 6 weeks of treatment to people who didn't respond initially. So you're right. They're not exactly the same as the underlying population. They're people who didn't respond to the first 6 weeks. But I'm just not sure how clinically or not clinically relevant that is because, we're kind of playing the long game in addiction. So if you didn't respond for the first 6 weeks of treatment, like I know a lot of patients who didn't do great in the first 6 weeks of treatment and then eventually were successful. And of course, they're not like in a study, but like, I don't know, the first 6 weeks is just like a drop in the bucket of what you're looking for. So I'm actually not sure that's how different those patients would be. Maybe, I don't know. Do you think that makes a big difference for this sort of second group, that they're non-responders for the first 6 weeks?
No, I think it just selects for like a group that probably is less predisposed to kind of the natural recovery.
Right.
Like, I think that was a board question for when I was just saying with the boards, like what's the most common kind of outcome for someone meeting criteria for alcohol use disorder? And basically it was like non-abstinent recovery of the condition. So basically like, people do kind of gradually change behavior, and it may not be what you think of as treatment, but they will kind of gradually change behavior to kind of not meet the criteria for the disorder in many cases.
Mm-hmm.
So what are the results of it? To kind of summarize, the Naltrexone and Bupropion group was more effective, and that was statistically significant in kind of stage 1, stage 2, and the combined stages. So when you look at it for stage 1, there was an 18.4% increase in chance of methamphetamine negative urine drug screens in the treatment group. That was statistically significant, p0.001. In stage 2, there was a further 9.2% increase in methamphetamine negative urine drug screens. That was statistically significant, p0.038. In the combined stages, when you put both together, there was a 27.1% increase in chance of methamphetamine negative urine drug screens, and that was highly significant, p less than 0.001. When you look at the placebo comparison, kind of interestingly, like stage 1 and throughout the trial, there was an increased chance of methamphetamine negative urine drug screens in the placebo group as well. And when you look at stage 1 and the combined stage, it was statistically significant with a 7% increase in methamphetamine negative urine drug screens during stage 1 with the placebo, and that was p0.008. And then now in stage 2, it wasn't statistically significant. It just barely missed that with another 3.9% increase. Well, when you look at this composite increase over the combined stages, 11.4% increase in methamphetamine negative urine drug screens in the placebo group throughout the trial, p equals 0.002. And it was relatively stagnant in both groups in the post-treatment phase. So like it wasn't like there was a massive regression or continued improvement either, kind of reliably.
One thing I'm noticing from these results, it reminds me a little bit of our study from a few episodes ago about treatment-resistant smoking cessation. Like, it gives you hope that if you try this treatment for a month or two and it doesn't work, you can kind of try it again or like keep trying. And there's a non-zero chance that it will work kind of the second time. So it gives people some hope. You can say, look, it didn't work the first time, but let's try again. Let's just, do another injection, because patients can say, look, I had 2 shots. I'm still using methamphetamine. You'd be like, let's just keep going. Let's give it another try. So I like that from these results.
It makes me feel optimistic that people do better with time too. Like, I feel like, we like to think that we're so important that we save everyone. It's nice to see there's just improvement too, that people change positively on their own, even if not to a degree as much as we can help them with. So they talk about difference chances between the two groups. So to summarize it, while both groups did improve, there was a statistically significant improvement of about 15.8% with treatment that you're going to have a methamphetamine negative urine drug screen when you compare that to placebo. So the treatment was effective to that regard, and that was statistically significant at p 0.006. So, like, as I said, kind of like a relatively short article in terms of like brief facts to give, but I thought it was pretty interesting. And I kind of always kind of like break this up, kind of like, does this help me with my patient care? And I guess kind of starting with, methamphetamine use disorder, it's challenging for us. I think there's a lack of FDA approved treatment options. Kind of current standard of care is contingency management, which if you've never heard that term listening to the podcast, it's basically you kind of like provide rewards to patients with urine drug screens that are negative for a substance. In some states like California, there's funding actually out of the budget that this is paid for as part of medical services. In many other states, it's not. So it's kind of grant reliable. So people, I know like one of my friends that works down in southern Georgia, in rural Georgia, he had this at one point in his clinic, but it was through a grant. And then the grant dried up. So year one, it was effective. And then year two, the money dried up and like the program, like, the results kind of fade away without that. And I think we've talked before, it's not a very large amount of money, surprisingly, to get results. I want to say it's somewhere around $100 some, like just barely, certainly much less than a GLP-1 agonist or an SGL2 inhibitor.
That's right. Little dig there from a family practice.
Then, like an ideal solution for me would really to be kind of have access to a medication that's effective. Like I like buprenorphine particularly because it's easy to use. It's very accessible. It works well. I would love to have like some sort of like cousin of that at some point for methamphetamine and stimulant use disorder in general. We currently don't have that. So I like the idea of this study. The study does give me some optimism that it suggests that kind of the combination of long-acting naltrexone and bupropion can improve methamphetamine negative urine drug screens by a statistically significant result with a 15.8% difference between the two groups. Although, there's a couple barriers there. I don't know if I could get long-acting naltrexone approved for an indication of methamphetamine use. I don't think insurance would pay for it. It's a relatively expensive medication. And not only that, so I'd have to probably kind of infer the results even further with oral naltrexone due to cost and insurance coverage, which we know in other substance use disorders is inferior to the IM due to patient adherence. So I like having this tool here. I don't quite know how to synthesize all of this information together for my day-to-day practice, which is a very opioid-heavy population also using amphetamines. Or methamphetamine, but I do think that kind of off-label use of this would be effective. My only kind of, the biggest thing I feel like I kind of, not to critique, but I kind of feels like limits the study a little bit to me, is that, the kind of gold standard in addiction medicine for success in these trials is drug screen results. And I think as I practice more and more, I'm less enthralled by that marker. And I don't think most patients would feel that that's a patient-centered marker of success. And I'll be honest with you, I feel like my view of drug screens at this point is really they're conversation starters more so than anything else. They're not really kind of a metric of any success that the patient or I are having. So I think while like kind of difficult to generalize these results, like for a narrow subgroup, I could use this, and I would just have to figure out how I'd get the naltrexone approved, but I'm sure I could find something.
Yeah, well, right. And you can sort of infer patient satisfaction with the treatment by looking at something like dropout rate, but you're right. There's not a lot of like data about what do the patients think about this treatment, And there's no data about reduction in use. It's just like, was there no meth in your urine? That was considered sort of the final outcome. I know I disagree with your interpretation. I'll use this if someone can take naltrexone and is having trouble with buprenorphine. Like I don't see any better data for anything else, but I haven't had the chance to use it yet. And as I said, all my people are on opioids, so naltrexone's not a great choice. Well, thank you, John, for presenting that article. Given the lack of data to treat methamphetamine use disorder, it's super important. So I'm really glad that you presented it and then we can share it on the podcast.
You said naltrexone is not a great option, although I will say, I guess maybe this could factor, now I'm thinking about it out loud, into initial drug selection. Like, when you're talking kind of at starting therapy, I think like, it's a little bit more nuanced to get people onto IM naltrexone than it is, you have to have a washout period like 7 to 14 days. But I think that like that would be a good conversation point. Like if a patient has like people have varying degrees of substance use disorder. They were a severe methamphetamine use disorder, just like my severe alcoholics that also have meet mild criteria for like opioid use. I think that this is a conversation that maybe that might be a better fit for them.
Right. Like if they have alcohol use disorder or they want to use naltrexone to treat opioid use disorder, if methamphetamine is the drug of choice, but there's still some opioids in the mix.
Or like how many people with alcohol use disorder, like they meet criteria for severe alcohol use disorder and they meet mild criteria for opioid use disorder. And like we put them on buprenorphine because it's easy and like people want it. But this might be a good conversation starter.
Yeah, it's true. Actually, if you're thinking about really the polydrug situation, right? Maybe there are patients who want this. I guess I'm just so biased. Everybody I know wants buprenorphine because that's kind of the point of my practice. So people who don't want buprenorphine aren't necessarily coming to me. I only have had one person recently who requested naltrexone injection.
I've got probably a dozen, not a dozen, probably got like about 10 patients currently on IM naltrexone. I think it's a combination of also like not many people offer that in my area. Right. So like I get referrals, but I have some patients that just feel like that's a better fit for them. Like as I said, it's often people often meet criteria for alcohol use disorder as well.
Yeah. Cool. Hey, I wanted to share with you and with our listeners a little bit of talk back. We got all kinds of comments about episode 46, which was high-dose meds for smoking cessation. So the first thing, someone did point out an error I had made in the podcast in which I said exhaled CO2, so carbon dioxide, to verify smoking status instead of inhaled carbon monoxide. So yeah. I apologize for that. I can't change the recorded audio, but here's my errata in this comment.
We record late at night and we're tired sometimes. So I feel like
we are tired.
We're trying, man.
We have day jobs. But no, I super appreciate it. And, if anyone ever hears us say anything wrong, please send us emails or correct us in some way. Second, we talked some about how abnormal dreams are a feared side effect of nicotine and varenicline for smoking cessation. And I put out a little poll on our various social media about whether or not everyone out there counsels patients to take the nicotine patch off at night to prevent weird dreams. And John said that he was taught you always do that. And I had never told someone to take the patch off at night. So I put out a little call. And of the people who responded, 17% said they tell patients to take it off at night. 75% said they tell people just to leave it on, and 8% said whatever, they don't care. And so, but several people specifically mentioned that if the patient has a history of trauma with the possibility of vivid nightmares, you should be more careful to counsel them to take it off at night. Someone emailed us, a Dr. Shay Mitliner, I hope I'm pronouncing your name right. She wrote to us and said, I worked on an inpatient withdrawal management unit for 26 years. And we always told the clients to take the nicotine patch off at night. Many reported weird dreams, and since there was a high rate of our clients who had trauma histories, it was really important that they took the patch off at night. Some other people had said that if a patient had experienced bad dreams in the past as well with a history of PTSD, those are people you counsel to take the patch off at night. So, a little more nuance than just always or never do it. And then finally, I got a little bit of chastisement from Dr. Scott McCracken for being dismissive of how important and troubling this side effect can be for patients. I was sort of like, look, just suck it up. How bad can it be? And he reminded me it can be pretty significant and something that really bothers people and can prevent them from being successful with smoking cessation. So I appreciate that feedback as well from Dr. McCracken. I did pose a question that no one answered, so I'm going to put it out there for you, John. If weird dreams are a side effect from varenicline, can patients just take it in the morning? Like it's supposed to be BID dosing. Could you take it like breakfast and lunch? So it's less of it in your system overnight to prevent the weird dreams?
I mean, it's America. You can do anything you want.
It's a free country.
But I don't, that's an interesting question because I do ramp people up with starting it once daily. I've never thought to ask, do the dreams not occur when they first started? And I'm doing that because the biggest thing about the ramp up is the nausea, right? People get really nauseous on these meds. And so like slow dose escalations make that more tolerable. But I never asked if they get the nightmares only after they switch it to BID.
I suppose I could have looked up the pharmacokinetics of it to see how long the half-life is.
No. We're just guessing right now.
If anyone knows, they could tell us.
I'm going to ask that, though. I mean, I prescribe this like 12 times a week.
Right. In fact, we have a meeting with one of our pharmacists tomorrow morning in like 7 hours. So maybe we can ask him. Well, everybody, on that note, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say about varenicline and weird dreams and everything else. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links will be in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.